anybody a few minutes before we get started here. Just checking everything out. Okay. All righty. All right. Well, hello, everybody. My name is Dr. Brian Pekarski. I'm a physical therapist, the owner of Core Matrix Physical Therapy, and I am a vestibular specialist and a McKenzie certified clinician. And today I will be discussing a Q and A about vertigo. So over the last few weeks, I've been putting out questions and fielding questions from various people online, but also various questions I've heard in my practice. What is vertigo? And we're going to talk a little bit about the main questions that I hear consistently and also have fielded from other people on different social media outlets. So this will be one of many webinars, question and answer seminars I'll be doing over the next year. So each month, stay tuned for a different topic. And here we go. This should be a lot of fun. So part one. So the first question I get is, what exactly is vertigo? Okay, so vertigo by definition, it's an illusion of movement. Okay, it's a type of dizziness. It's basically described as a spinning sensation. Okay, and people will feel when they have vertigo is a sense that the room or the environment is moving or spinning when you are actually still. So people feel things are moving and they're not, but you are, because you're getting a false input from your inner ear because you have a disorder of your inner ear. Okay, and then also people will feel off balanced. Sometimes you get a sense of lightheadedness, a sense of disequilibrium, a fear of falling. All these things can be related to a sense of vertigo. But vertigo can also be caused by other medical disorders. And the most common that we treat clinically as physical therapists is BPPV. And all that abbreviation is for, the B is for benign, which means it's non-life threatening. P is for paroxysmal, which means that it comes and goes. It's not constant it's not all the time with positional vertigo. The second P is positional, which it's brought about by positions usually of the head and or the body. And then vertigo, the V, is the sense of spinning. So by definition, that's what vertigo is. And there's a lot of different factors that go into vertigo. And we'll touch on some of those as well. So that's the first question I get a ton, and that's kind of the answer for that. So let's look at question number two. So what body part is vertigo most likely associated with, commonly associated with? So this would be the ear, particularly the inner ear. So I'm getting my little model here. Okay, so this is a model of the ear. If everybody can see that. So here's my outer ear, and I take this top of the bone off, and sitting inside here is the inner ear. And this right here, this little structure is the main cause of vertigo, for positional vertigo. But this is your inner ear, and this structure here is critical for your balance and your vestibular system. So basically, when you look at this little design here, this little piece is called a cochlea. It looks like a snail shell. And then you've got this little kind of wide part here. This is your saccule and your utricle. So basically what this is the saccule is like it's a little organ inside the inner ear where these little crystals, or calcium carbonate crystals, that are housed inside this inner ear that are normal and should be produced. And it gives us a sense of equilibrium. And sometimes when these little crystals aren't where they should be, that's when you get a sense of a positional vertigo. And you can see all these little lines here, these are called semicircular canals. And there's three of them. There's an anterior, which is a top. There's a horizontal, which is horizontal, obviously. And then there's a posterior, which is a backward. So normally these little calcium carbonate crystals should be housed within the saccule. Okay. But sometimes, and again, this is where positional vertigo comes into place, sometimes there's a critical mass of these little calcium carbonate crystals, or autoconia. And normally in a normal situation, that these little crystals will get absorbed, and they're microscopic, right? Sometimes though, they cluster, they fall out, or they go where they shouldn't go, and they go into these semicircular canals. And that becomes a problem with the sense of vertigo, because normally inside these there's fluid. And as you turn your head, your inner ear tells your brain kind of what's going on. When these crystals aren't where they should be, there's a disconnect. So your inner ear is getting a different input from your eyes, and then your brain's interpreting what's going on, and it's not accurate. And that's that sense of that illusion or that sense of spinning. Okay. And these crystals will go out of place usually with a head position, quick movements, and then you just get a wrong signal and the brain thinks you're moving and you're not. So that's the first type of vertigo. It's BPPV, or positional vertigo. And truly it's a mechanical problem. Something isn't where it should be. Okay. So we need to figure out, which canal is it as therapists or as other healthcare providers, and how to put it back where it's supposed to be. Okay. So the second type of issue in the ear is called Meniere's. Now, Meniere's disease is basically, it's a fluid buildup in the ear, and this tends to cause vertigo and ringing in the ear, or tinnitus or tinnitus, depending how you say it, tomato, tomato. It doesn't really matter, but it's ringing in the ear because now, instead of a crystal issue, you have fluid that's building up somewhere in this ear, and it's causing this pressure and this disconnect, and you're getting this wrong input again. Okay, and you're getting this vertigo type symptom. So again, this is more of a medical issue, and definitely you need to make sure you're hooked up with an ENT and maybe a neurologist, depending on other symptoms, but you definitely need to have that checked out. The third type of vertigo diagnosis or issue that we see is viral infections. Okay, the most common is called a vestibular neuritis, which is an inflammation of the vestibular nerve, which is coming outside of the cochlea here, or labyrinthitis, which are just canals inside the ear. So inflammation of these structures will also cause vertigo, and this is an infection, viral infection. So this needs to be treated medically, and typically when the infection is resolved, the vertigo will go away. Now there still could be some issue with balance and just input. So those are things where vestibular therapy can be of help. So those are kind of the common types of vertigo, and what this little structure in the inner ear can cause havoc on the body. Okay, so that's question number 2. So question number 3, so what causes vertigo? Okay, so vertigo it's multifactorial, but any kind of balance or a hearing disorder, loss of hearing, tinnitus, that can cause a sense of vertigo or a sense of disequilibrium. Any kind of head trauma, if you had a head injury, you're in a motor vehicle accident, a whiplash accident, if you have a history of migraines, that pressure can cause a sense of vertigo. Ear infections, viral infections like we just previously discussed, or even different types of medications, especially blood pressure medications, because if your blood pressure drops, you will get dizzy. Normally that happens when we roll or we get up, that blood pressure does drop. But if somebody has a lower blood pressure and they're on meds to lower it even more, there's more of a sense of vertigo and dizziness. So you want to make sure, if that's an issue, that you talk to your primary care provider, make sure that different medications are adequate, because a lot of polypharmacy, a lot of the medication side effect is dizziness, and too many of those side effects, this just needs to have your medicines checked out. So all of these issues will affect your inner ear. And again, that's where the problem is. This little structure here affects your balance component. It affects the input for your eyes and your brain to connect. Okay, so then that's when it leads to vertigo, disequilibrium, nausea, and even vomiting. You get a visceral response because all these systems are out of whack, and one doesn't know what the other is doing. And because there's either a mechanical problem like a crystal, or there's a viral problem, it just throws the whole body in a tizzy. So those are just some things that can cause vertigo. So the next question we have is, what are the symptoms of vertigo and balance problems? Okay, so as I've talked about before, one of the most common problems with vertigo is spinning, okay, or the sense of just illusional movement. Even though you feel it's real, it's really an illusion because it's faulty input from what's going on inside this inner ear. Okay, another thing that people will talk about with vertigo is feeling tilted or feeling off kilter, or they feel like they're swaying, or they feel like they're walking or veering when they walk. Okay, feeling unbalanced or fearful of falling. So all these go hand in hand with a vestibular issue or vertigo issue. Okay, other symptoms that can accompany this is obviously the nausea that we talked about before. Headaches can cause, like, especially with migraines, you can get a headache. You can also have light noise sensitivity, especially with a migraine, or even like an upper neck or upper cervical issue, which we'll discuss a little bit later. Some other uncommon and more severe symptoms you want to look for is any kind of double vision, or we call that diplopia, or any kind of sweating or loss of weight. All those things can be considered red flags. You definitely need to make sure you're in contact with an ENT or neurologist, even your primary. Make sure the doctors are on board, and make sure you don't let anything, let anything go away that could be an issue potentially. So vertigo also, the symptoms of vertigo, they vary depending on the type of disorder. So as far as a positional vertigo or BPPV, I mean, this can usually last seconds to up to a minute, versus other disorders can last for minutes. Some can last for hours, some can last for days. So truly depends on if it's an infection, if it's a Meniere's, if it's some other kind of vestibular disorder. You really need to figure out what is your diagnosis, what is going on, so your provider, your specialist knows how to treat it. So those are just some of the symptoms about vertigo and how they can relate to the balance. So that's question number 4. I think we have about 14 questions that I saw that we'll go through today. Okay, so here's the next question. Is somebody asked me, why do your eyes feel jumpy when I'm dizzy? Okay, so this is really a hallmark of the BPPV. Okay, so again, this mechanical issue. And this hallmark, or this eye dysfunction, is called nystagmus. So normally when we look at something, or we're tracking like with our finger, or we're looking and scanning the environment, our eyes move very smooth. So we don't have a problem. We can turn and look our head, move our eyes. We don't have any dizziness, or our eyes track nicely. Now nystagmus it's kind of a jerking response. So your eyes will involuntarily move because there's a disconnect between this inner ear and your eye, and then your brain's interpretation. So instead of a smooth transition, you get this kind of jerky kind of movement. You twist your head or move your head, and it's just kind of like a catch-up movement. It kind of jerks, and you can see kind of, it's not smooth. It's very easy to see because you can see the eye and the pupil. It'll kind of jerk back instead of a smooth movement. It's kind of like almost like a ratchet move. Okay, so this is important because clinically, with any specialist is evaluating somebody with a vestibular issue, moving the head quickly, we look at the eyes and we look for, we call the catch-up saccade, and we can see that nystagmus kind of jumping based on how we shake the head. It gives us an idea, or at least a clue, on maybe which side or what ear. What is this? Is this a positional vertigo issue, or is it something else? So it really gives us some input, because really the eye is the window to the inner ear. So it's really important that you get a good diagnostic from either your physical therapist specialist, your ENT, your neurologist, you're in your primary. So really it's a thorough evaluation really makes or breaks the diagnosis. Okay, so again, that's just that nystagmus. It's just an abnormal involuntary movement, that because your eyes can't focus on what's happening because there's something wrong in your inner ear. Okay. So question number 6 is, can vertigo be treated? And the answer to this is obviously yes. So again, depending on your diagnosis, physical therapy, hallmark for a lot of vestibular issues, especially BPPV, any kind of weakness, balance issue, hypofunction. Sometimes medication is needed, especially if somebody has persistent vertigo, dizziness, or if they have like some visceral responses, nausea, vomiting, things like that. Medication should be introduced, and again, your physician or ENT or neurologist would be able to provide the necessary medication for that. And occasionally there's surgery, surgical intervention could be advised depending on the severity of a structure. But as far as for BPPV is really the least, really it's benign, it's non-life threatening, but really that diagnosis or that problem will pretty much resolve with time. So again, it's very short-lived. So typically a few seconds to up to a minute is it. And once you get out of the position that causes your positional vertigo, it will resolve. It doesn't linger like a Meniere's or a labyrinthitis or any other kind of vestibular disorder. So it's very intermittent, and it's always triggered by movements of your head or your eyes. So, and again, the BPPV will never be constant. That's really the key to knowing that diagnosis. But again, physical therapy, either we use canal repositioning techniques where we're actually taking these crystals and mechanically putting them back where they should be, outside of those canals. We also use vestibular rehabilitation techniques, which we'll talk about in a little bit, a couple other slides about what types of therapies can be done. So being it if you have trouble with focusing, if you have trouble with the balance component, you have trouble in different environments, it's all just a matter of, where's your functional deficit and how can physical therapy intervene and help you get back to your level of function. So that's the answer. Yes, therapy can be treated and very effectively if you get the right, you do the right diagnostics and the right clinical examination. Okay, so question number 7. So another question I get quite a bit is, at what age is the vertigo most common? Okay, so um, studies will show that in the early 20s is a normal kind of onset where this can happen, and in all ages commonly after that. So typically they say as the decades increase, the chances of vertigo can increase. Um, and again, there's a lot of kind of, nothing's really set in stone on why this happens. There's some speculation that inside the inner ear, the membranes are kind of sticky. And as we get older, they dry a little bit, and these little otoconia that should be housed in this little saccule here, utricle and the saccule where these little otoconia are, they don't stick as well. So they easily or more easily can fall into the canal where they shouldn't be. Because again, that disrupts the input from your inner ear to your eye and to your brain. So again, age has some role, but they're still not 100% sure why. But I think part of it is some of that, just that stickiness of the membrane is just not as adherent as when you're younger. The problem is, though, as we get older and we have vertigo issues, we have more balance issues because we have other, usually orthopedic problems. We have hips and knee joint issues, pain, some visual problems. Sometimes there's an assisted device. So with a loss of balance and a fall could result in a fracture, which is never good for anybody. But especially as we get older, that risk increases, and then the likelihood, mortality, but also we're talking long rehabs depending on what you break, or even head injury, or even death. So, it's pretty scary. So it's really key to be on top of these types of issues, or if your loved ones are having some balance issues, have them evaluated by a physician, maybe an ENT specialist, and definitely get them into some kind of physical therapy regimen on an in-home program. Would be a great thing for them. Okay. So number 8. So this next question is kind of an interesting one. So question is, how is vertigo different than dizziness? So this topic's a little confusing and it's commonly interchanged, but the true definition of these two disorders is kind of interesting. And once you know them, it'll make more sense. So dizziness is typically referred to as lightheadedness. Okay, and lightheadedness or dizziness does not involve spinning. And this is not true vertigo. Okay, so when you have lightheadedness, typically you're thinking of like a cardiac issue or a vascular issue. There's a blood flow issue, possibly. There's a cardiovascular issue because, again, lightheadedness is more of a systems disorder versus vertigo is a spinning, it's an illusion, it's a mechanical issue inside the inner ear, and it's only with head positioning. Okay, and again, vertigo is just an illusion, and it always involves spinning, and lightheadedness is never involved with spinning because it's not true vertigo. So you always want to consider or think of in your back of your mind is having a cardiac workup. If you do have the lightheadedness, make sure blood pressure is, because again, blood pressure medications, depending if somebody's taking them, will, suppress the blood pressure issue. So if somebody has a low blood pressure or high blood pressure, they're taking too much of the meds and they're low, and then you get up and you're low, and then there's where you're going to be dizzy, is change of position naturally decreases blood pressure. However, if you're already on a medication and you're dizzy and then you're more dizzy and you're fainting, that's more from the heart, and you definitely want to get a cardiac workup. Talk to your primary about that, maybe doing some other diagnostics. For vascular, they might want to check the carotid arteries and make sure all that there's no blockage in there too, because all those things can cause some problems. And lightheadedness is definitely a cardiac/vascular issue that should be looked at. Okay. So number 9. So here's a big one, and this is my world, So how does physical therapy help with vertigo? Okay. So it truly depends on the diagnosis, and we really need to do a good job evaluating patients, not only as physical therapists, but also primary cares, ENTs, neurologists, cardiac docs. So, there's definitely has to be good communication between providers. But from a physical therapy standpoint, we do our clinical examination based on, our clinical exam and tested measures, and we can kind of figure out, what system is involved and how do we treat it. Okay. So, the biggest one and the most common problem that we see clinically as physical therapists is BPPV, because it's a mechanical functional problem that can be treated with positioning maneuvers. So again, if we go back to little inner ear here, and you look at the cochlea and you look at all our different canals, all right, so depending on which canal, and again, we need to evaluate, and vestibular specialty therapist or trained therapist know how to look at the different canals. Okay. And that's what we do, is we put people in testing positions and we try to figure out what stems a response. And a lot of times this will be explained and talked about from the patient. They'll tell you what makes them dizzy. They're going to know, I'm dizzy when I turn my head to the right. I'm dizzy when I get out of the bed. I'm dizzy when I stand up. So all those things kind of trigger and give us clues on, maybe, is this positional vertigo? Does it last a few seconds? Does it last days? Okay. So that's a big difference and changes our thought process on what the actual diagnosis is. Okay. So if we do decide that, or we hypothesize, because we're not sure until we test, BPPV, we're going to look at canal repositioning maneuvers and techniques. And these are different. We're going to put the head in different positions and see if it sparks a response. And that response will also be treated using gravity. And we'll talk about this in later webinars, but just in general, we're taking this mechanical problem and we're fixing it. We're putting the crystals back in the utricle and the saccular where they belong, and not in the semicircular canals, causing this kind of cluster and this movement of fluid that your brain is sensing there's movement and there's not. It's just, there's a whole system flaw. So this mechanical issue is a fairly easy fix if you get the a trained vestibular therapist that knows and is comfortable with the positions. Okay. The second type of problem with vestibular rehab is if there's a damage to an ear or weakness. So a lot of times we'll call this a hypofunction. It just means there's a weakness. Why is that? A lot of different reasons, as we talked about before. It could be an infection, it could be damage to a nerve, could be head trauma in the past. And this is where we use our vestibular rehabilitation techniques. So basically we call VRT is vestibular rehab therapy. And basically what we're trying to do is we're trying to improve somebody's function. So depending on where their functional deficit is, that's how we treat them. Okay, so positional vertigo, we're going to basically mechanically change the alignment of the crystals, or the autoconia, or ear crystals, which people always say, oh, they put my crystals back. Yeah, they're calcium carbonate crystals, but normally they're in the ear. And again, with a BPPV issue, there's either too many, because normally the body can absorb a small amount of the autoconia. But when they clump, or if they get lodged somewhere and the body can't absorb, that's that mechanical problem that causes vertigo. So we have to actually use gravity to put it back into where it belongs. Okay, so that's what we do with that. So if there's a weakness, or we need to incorporate more of vestibular rehab therapy techniques, there's three kind of categories that we look at. The first category is called gaze stabilization. So this is involved when people have that trouble with their eyes, or having trouble focusing. So when they're trying to read things, there's that bounciness. Things aren't clear when they turn their heads quick and they're looking over their shoulder or driving. They get that dizziness, moving their eyes quickly, or their head. So there's symptoms and there's dizziness. So, we call this reflex called the VOR, is a vestibular ocular reflex. And what we want to do is train that by using certain exercises to both just move your eyes, which is called saccades, when you just kind of move your eyes between points, or we use head movements, which is the VOR. And this is where we focus on different things such as an X, or we look at different environments and we're moving our head and working on different angles, ups and downs, side to sides, diagonals, circles, whatever the functional impairment that we find is, we need to work on improving that, so the patient or the person can function in society and not have that sense of dizziness or that fear of falling. So that's gaze stabilization. So we're working with the eyes and the head movements and trying to resolve that fear of dizziness, and knowing it's okay to move, and teaching strategies on how to move. Excuse me one second, I need a drink. Okay. All right, so the next type of therapy is called habituation. Okay. So habituation is again, we're dizzy with quick movements and positional changes, and then we're in different environments. So this is basically your functioning. So you're walking in a busy store and you're turning, and the sense of the stimulus is kind of overwhelming, and turning quickly makes you dizzy, and maybe you veer to a side. So there's a lot of systems are involved here. So you got your inner ear, you've got your eye, and then you got your brain interpreting this. Okay, so it's like a heightened vestibular system. What we have to do is we have to train in these systems and start in an easier way to give somebody success. So we start in a very calm environment, but doing the movements and maybe walking and just looking at maybe a spot on the wall, or using a little index card or a little sticky note. And as we're walking, we're turning left and right, or maybe up and down or side to side, changing positions with this, and then progressing that to maybe walking in the mall and looking at something. Um, doing different environments, doing obstacle course type things. So really what we're trying to do is train your body to get used to environments that are overstimulating. So we try to habituate, we try to our habitat a little more stable by practicing in these positions and in these environments that are very noxious to our vestibular system. Okay, so it's really, a lot of times people say they're scared to do vestibular therapy because it makes them worse, but it's important that you have to work through it, and sometimes you have to start slower than others, but it really just depends on the individual and what they can tolerate. But the goal, the end game, is to be able to progress that they can work in that environment, they can work in a busy environment, they can walk in a mall, they can go shopping, or whatever their functional deficit or their trigger is. You have to work through that and give them strategies. Okay. And the last kind of big category of vestibular rehab is called substitution. So substitution is basically, now we're working on the muscles and we're challenging different balance techniques. We're doing things, standing on one leg, standing on two legs, eyes are open, eyes are closed. We're doing different functional movements like squats and lunges and things like that, working on different balance boards and beams and things like that. Again, we're challenging the muscles. So these are really good, for some of our elderly folks that we treat, or just, if somebody's so heightened and they can't even move their head, or they're having really trouble with gaze stabilization or habituation, starting in substitutions a little bit of an easier to give them a little more confidence. And you're just working on the larger muscle groups and just keeping the head more kind of centered. So you're not focused, you can focus on one thing and not all these multiple environmental stimulus. So those are three main categories for vestibular rehab. And what we do as therapists, and also in conjunction with other providers, ENTs, neurologists, and primary care physicians. Okay. All right, so let's see, what question number 10. Okay, so another question that I had from an inquiry was, what causes pressure in your head when you're laying down? So this is kind of a tough one, because there's so many things, multiple causes, multiple comorbidities. One of the biggest things we think about or hear about is either sinus or ear pressure or congestion. High blood pressure might cause that extra pressure in the head. So if anybody has these types of problems, you definitely want to talk to your primary, and most likely get an ENT consultation, and have them just kind of check your sinus cavities out. Make sure your blood pressure, cardiologist, make sure blood pressure is okay. Maybe check your own blood pressure and just see how it is, when you lie down, when you sit up. You could have some drainage issues there. So that's kind of a tough one. There's, medications could be a factor. The height of your pillow, just so many different factors. So that's not really an easy question to answer. So really, if you have pressure, typically, you want to have that looked at by your primary care, and likely an ENT or a cardiologist, depending on where this pressure is. Is it like a sinus pressure? Is it like a throbbing headache pressure? Is it vascular? Is it from like a migraine? Is there some kind of benign thing we're not sure of? So definitely want to get a workup and find the root cause of that, because there could be a lot of different things. But typically, sinus pressure or pressure in the head doesn't typically relate to any kind of positional vertigo issues. Okay. So number 11. So this was another question or inquiry that I received. So this one is, how do I prevent vertigo reoccurring or reoccurrence? Okay, so this is an interesting topic because there's a couple risk factors for reoccurrence of vertigo. One of the main reoccurrent issues for vertigo is somebody over the age of 50. So again, for whatever reason, and I think just anatomy wise, and I think those the stickiness of the membranes might have something to do with that. As we get older, they're not as adherent and things can slide and get dislodged as well. So that's one of the things. Another thing is it could be the way or the positions, whatever your therapist or ENT, whoever did whatever technique they might have done. So again, one of the common things is if somebody treated and just assumed it was a posterior canal, for instance, and the Epley is a common positional maneuver for that. A lot of people will just tend to do that first, and it might not be the right canal. So if you're doing a posterior canal maneuver on somebody with an anterior or a horizontal canal problem, you might actually make it worse. Or if they had a little bit of a result from the posterior canal, whatever maneuver somebody would have done, and then time went on, and then it slipped into a different part of the canal, and that's a whole nother problem. That's probably one of the more common issues, is it migrates to a different part of a canal. Another issue is if somebody has a history of like head trauma or head injury, there seems to be it takes longer to heal, and there seems to be more of a recurrence rate just because of that trauma. Another side effect or another issue with recurrence is having a diagnosis of osteoporosis. So again, there's problem with bone absorption anyhow with osteoporosis. So maybe those otoconia are just, they're just not absorbing, and they're just getting in the way and causing that blockage and that sensory malalignment. Sometimes, like I said, the otoconia will just maybe, again, and there's different types depending on what type of BPPV somebody has. So sometimes there's the canal, it's real quick. So a couple seconds and you can move to the next position. Sometimes you have to wait a little longer depending on, how fast is the otoconia moving or how slow is it. So if somebody didn't get a full resolution of symptoms or didn't hold the position long enough and they thought it was a cupuloaesthesis and it was something else, maybe that's part of it. So canalesthesis versus cupuloaesthesis, it depends where it is, and if you don't hold it long enough, then the symptoms don't resolve. So again, it could be a technique thing. So really the positioning is key. If your positioning is not 100% on for the canal you're looking for, that in itself will give you an issue. You won't get full resolution of symptoms, or you might partially resolve it. It might be close to inside the utricle or the saccule, but it's just still hanging out a little bit, and it's still triggered by movements. Okay. Another thing that they say is one of the studies, or one of more recent studies, said that a lack or low vitamin D3 level can also be a risk factor or a cause of reoccurrence of, positional vertigo. And again, that's some interesting things that they're finding, and there's always new things. And then, again, there's still a lot of unanswered questions regarding why do some people have more recurrent vertigo than others. So again, there's still a lot of things out there, a lot of philosophies out there. Studies are always being done, but those are kind of the top things that happen. Another thing that a lot of people don't realize is sometimes vertigo can be, reoccurred by just positioning, like say, for instance, in the dental chair, right? So if you're back in a dental chair and you're getting dental work and you're getting a drill or you're getting, a cavity filled, the vibration of the drill can actually jar otoconia. And if you already have like an issue with BPPV, just by getting some dental work done might dislodge that otoconia in the canal. Or another example for that would be, say, at a hairdresser. If somebody's getting their head back and getting their hair washed and they're scrubbing, getting their shampoo and conditioning, all that good stuff, that jarring or that movement is sort of a positioning of a Hall pike, which is a test that we assess for positional vertigo. So again, simple things like that, yoga positions, like a downward dog position, if you do that quick enough, and if you have a little bit of a vertigo issue, guess what? That can be another cause of a reoccurrence. So those are just some things to kind of consider if you're having more frequent episodes of vertigo. Just some kind of interesting tidbits there, but still a lot of unanswered questions, and research is always looking for figuring out why is this the case. Okay, I think that answers number 11. Okay, so number 12. So this is what somebody asked, what is PPPD? And is this a real thing, and can therapy help? So PPPD is a newer type term, and basically vestibular issues, they like to use acronyms because these words are just a mouthful. So it's persistent perceptual postural dizziness. So PPPD. So we'll just go with that. But basically, it's by definition, it's a persistent non-vertiginous dizziness, unsteadiness, or both. So again, you could have this non-vertigo dizziness and you're unsteady, or you could have your unsteady and you're dizzy. And the key, the criteria of this is it has to last greater than 3 months to kind of be in this category of PPPD. Okay, it's a crazy little word. So again, it has to be either the dizziness, instability, or both, and it has to be greater than a 3-month time of having this issue. Okay, so another common part to PPPD is the symptoms are present on almost every day, and they can increase and decrease throughout the day. So they can wax and wane. So you could be better in the morning, worse in the afternoon. The next day it could change. So it's very unstable. Um, you could get momentary flare-ups based on quick movements as well, and also can be flared by busy environments. So if you're in a mall or you're like in a Walmart or something, there's a lot of activity. This can actually spark PPPD, but it also can spark any other vestibular issue as well. But really, it's the key of how long it goes is the key for that. And why they say it's postural persistent vertigo is it's dizzy when you're upright, which is, basically how we function. Okay. And it's worse with moving environments. So again, driving, walking in a mall, in a store, in a grocery store, with any kind of complex visual stimuli. So a lot of bright lights, fluorescent lights, a lot of colors, cars moving, just all kinds of crazy things like that. And also can be influenced by either active, like moving your head, or somebody moving your head, passively. We call passive. Somebody's, not that somebody's going to sit and move your head, but any movement of the head can affect this or flare this up or provoke your symptoms. So it doesn't have to be just you moving your head. Like if you're getting therapy or a chiropractor, and if they're moving your head passively, that can also spark or cause this issue as well. Okay. So a lot of times also that these follow occurrences of other vestibular issues. So if somebody had like an acute vestibular BPPV or some kind of balance related issue, your symptoms might start kind of here and there, intermittent, like a BPPV, but it might progress too. It might be more constant. So that's another hallmark, another characteristic of PPPD. Um, and then again, the other thing is the symptoms, once they're fully evaluated, there's no other diagnosis or disorder that can be found. Okay, so they've kind of ruled out any other kind of like, brain issue, like any kind of tumor or any kind of blockage, so obviously there'd be some testing done, maybe brain MRI, maybe a CAT scan, maybe a carotid Doppler, and other testing, blood work. So all kinds of things will be looked out, autoimmune. So it's a pretty extensive workup, I would say, before you get to this diagnosis, because it's kind of like a taboo type diagnosis, like a fibromyalgia. There's no specific test for that, but it's a thing. It's a real thing, and a lot of it's hard to describe for people. So PPPD in a way is like that, because there's no true test to say, yes, I have PPPD or you have that. It's more on a cluster of symptoms, and it just gives you some guidelines. Okay. And the other thing, so the really big thing is the clinical history, knowing, what triggers, how long has this been going on. So the time of these episodes is key to figuring out, is it PPPD? Okay. And then other issues can be also related to any kind of psychological disorder. Okay. So there's a psychological component involved with PPPD as well. And it could be related. And there's still, a lot of studies being done on this because it's a relatively new topic. But any anxiety issues can flare this problem up. Post-traumatic stress disorder, so any kind of veterans or any kind of traumatic, sexual abuse type trauma history, anything like that, stress can definitely contribute to this as well. Okay, so again, then this compounding with this vertigo and then balance and instability, it's a lot going on. So there's a lot of systems involved. You know, there's a cognitive component, there's an emotional component, and then there's a functional component. So you've got a lot of systems going on. So this is a pretty complex diagnosis and really should be, you know, managed by different providers. So you definitely want to be involved with an ENT, a physical therapist, possibly a neuropsychologist to help you with coping strategies on how to deal with some of these symptoms, counseling if there is a history of any of those things like we've discussed with either previous trauma or PTSD or anything like that. And then treatments, you know, basically for physical therapy are going to be VRT. So we're going to do vestibular rehab techniques to help improve the function, help improve the balance, help improve integration in busy environments, improve confidence, improve, you know, self-worth through doing activities and starting with easier tasks and progressing and giving confidence to the patient. It might involve medication based on what the primary ENT, if there's a psychologist involved, they might need some kind of antidepressive. Again, this is a whole team approach for this type of diagnosis. And then usually some kind of cognitive behavioral therapies for coping strategies, you know, and how to deal with, you know, whatever issues in the past and whatever triggers might set you off. So typically if you have a multidisciplinary approach, the outcome is favorable. But it's not just your ENT, it's not just your physical therapist. You need multiple providers, medical providers, to address each of these components. You need the physical, you need the emotional, you need the medical, and then you need everybody has to be on the same page. And a lot of the times these people feel like nobody listens to them, and it's key to really understand that this is a diagnosis, and it's really misunderstood by a lot of providers. So definitely therapies need to be involved with this. Okay. I need a quick drink here. I'm talking way too much. Okay. So we're getting to the end of this first Q and A. So number 13. So this was a question I just received the other day. It's, can my neck cause symptoms? I was diagnosed with a vestibular migraine, but I never had any migraine or motion sickness or no family history. And this person stated that their imaging showed a lot of degenerative changes in their neck. So the question is, can neck cause dizziness? And the answer is absolutely. There's a condition when your neck is involved. It's called cervicogenic dizziness. So this condition is basically caused when, you know, there could be some arthritic changes, but basically there's a problem, there's a dysfunction in the upper cervical spine. So the upper cervical is like, there's your skull, and there's C1 and C2. C2 is like the big bump behind your skull, and C2 rotates your spine, your neck on your head, and C the skull to C1, it nods your head. So in that little section there's a lot of nerve innervation. And if there's any kind of dysfunction there, if the joint is rotated a certain way, it can rotate on an occipital nerve, and this can cause a headache. This can cause like a headache up in your eyeball. This can cause dizziness. Okay, the key with cervicogenic dizziness is there's always neck pain, almost 100% of the time, 99% of the time. And there's also a restriction in the motion because there's a dysfunction. The joint, every time you turn. So for instance, if I had a problem on my right side, every time I turn my right, I have pain on the right side of my neck. I turn my head to the right and I'm dizzy and I have pain. That's a strong correlation to a cervicogenic problem. Okay. And again, if you have neck pain and you're dizzy, that's the first hallmark thing you got to think about is this could be cervicogenic. Now, of course, there's other things you need to look at or have a provider or ENT or vestibular therapist or manual physical therapy or chiropractor. I guess a lot of different providers. You want to make sure that there's no instability. You want to make sure there's no red flags. So if anybody's having any, double vision, nausea, having trouble swallowing, having trouble talking, all these are red flags, and you want to make sure there's not a problem with the vertebral arteries. So if any of those things are going, if you're really anxious and there's tingling and numbness and things don't sound right, that's kind of a medical emergency. You need to get checked out right away. If you don't have those things, and there's clinical testing that a therapist, a vestibular therapist and manual therapist would do to make sure that your upper cervical spine, the ligaments in there are secure and safe, that you can do some testing. And then basically it's an evaluation based on movement and then based on symptoms. So if you find that there is a cervicogenic problem as a skilled therapist, a manual therapist, vestibular therapist with that training, it's a fairly easy fix, because once you restore your joint motion and you relax the muscles in the neck, and you learn how to stretch that, and you do the proper exercises, you can resolve that issue. And a lot of times when the neck problem is gone, the dizziness is gone. Sometimes there's some residual, but again, those are just the same. You look at the functional impairments. What can't these people do? And then you work on that. So really, you need to do a comprehensive neck evaluation. You have to screen for safety and make sure there's no red flags, no things that you need to worry about before you start working with anybody. And then also you have to do your full vestibular evaluation to make sure you don't miss any kind of positional vertigo. Okay. But typically, 9 out of 10 times, if somebody has neck pain and they're dizzy when they move their head to that side, that more than likely is a cervicogenic issue, because cervical is your neck, cervical spine, genic is just pain, right? So that's the issue. And when we would evaluate, look at the musculature around there, see how the joint moves and restore that motion, and then send the person home with the corrective exercises to do as tolerated. So yes, that is can definitely be a problem. And again, if somebody didn't know about it, that's just something you really need to screen and make sure there's no issue with it. Okay. And here is another question that I received. This was a few days ago. So this question is, how could a condition come so quickly? I go to bed normally, I wake up and the room is spinning with vertigo and 24/7 dizziness for at least 4 to 5 years. Okay. So this, this is a very interesting case. This doesn't sound very cut and dry, but just listening to that kind of subjective history, it's sounding a lot like PPPD. So for this type of incidents, when it's really not positional related and it's 24/7, so you already know there's no positional vertigo, because that's only seconds. Constant, when you have constant dizziness, you're thinking any kind of like maybe a viral infection, Meniere's. But the spinning part is an interesting thing, because spinning is truly a vertigo, and lightheadedness is not spinning, and chronic and constant for many years. So this would definitely be somebody that needs to have a medical workup. So definitely would have them, obviously, hopefully they've talked to their primary already, but definitely get an ENT, an ear, nose, and throat specialist on board, probably a neuro specialist, maybe a cardiac, maybe do some stress tests to make sure there's nothing going on there. But just waking up, that's an unusual symptom. So definitely it sounds like there's a medical component, but again, it could be a little PPPD as well. So again, a good root cause of this problem would be warranted. Check the cardiac component, make sure vascular is good, check out the ears and the nose, check out the brain, make sure everything's okay there. And then possibly some kind of a neuropsych component, a cognitive therapy component, and figure out, once you find the root cause, if there is anything to that, which it definitely sounds like there is. So, so that would be my suggestion for that situation. Okay. So if there's any other questions, I don't think anybody has any questions. So, okay. So that's pretty much what I had planned for today. So again, biggest thing today was discussing some of the common vertigo questions that I receive or have received in the last few weeks, or have seen in many years of doing this. And again, I'm Dr. Brian Pekarsky. I work for Core Matrix Physical Therapy. I do mobile-based vestibular therapy in Western New York. I also do telehealth in New York. And I'm also doing some webinars, and I'll be putting out some content within the next few months as well, for people can purchase or download, or just to help everybody. So hopefully this was helpful. If anybody needs to get in contact with me, you can check out the website is www.corematrix, vpt.com. You can also contact me. I'm on Facebook, I'm on Instagram, or you can DM me, and number it's area code 716-391-2236. Any other questions? But hopefully everybody learned a few things today, and if there's any other questions, feel free to send them to me, and we'll look forward to next month doing another Q&A webinar more related to the BPPV questions, and hopefully we'll be good. So again, I appreciate everybody's attention, and hopefully this helped. And my goal is just to help as many people as I can be aware of vestibular issues and how to go about finding the right care, getting the right help, and getting at it. So, thank you, everybody. Have a great night, and we'll talk again next month. Thank you.